We all know that women's health is important, and there's one woman who's been on the front lines nationally talking about it. Her name is Dr. Sharon Malone. Dr. Malone, first of all, welcome to Buffalo.
Well, thank you very much. This is my very first trip to Buffalo.
And it's so nice to have you here to talk about women's health, and I understand that you also have a book. Talk to me about the name of the book and what's the point of it?
You know, the name of my book is Grown Woman Talk, and I chose that title because it really encompasses a lot of the conversations. Remember how when you were a little girl and your mother would start talking to her friends or her sisters, and they would get to a point in the conversation where you had to leave, and my mother would say, okay, this is grown folks talk, and you had to leave. And I think that there are a lot of those conversations that we should have heard because we don't know enough about our health and the kinds of things that we should be looking for when we are grown women. And that was really the impetus behind the book. If you remember the book, What to Expect When You're Expecting, well, my book is What to Expect If You Expect to Live Beyond 40.
Interesting. And a lot of women are trying to make sure they live beyond 40 and be healthy.
Exactly. You know, I think that we spend a lot of time talking about lifespan, and yes, it's great that we've extended our lifespan. But what I want women to know is how to live healthfully, which is to increase our health span, not just our lifespan. It doesn't do you any good to live for an extra 10 years if 9 of that is spent in a nursing home.
What's happening? Why aren't women doing well?
Well, you know, I think that there are a couple of reasons. I think that women generally want to do well if they knew what to do. And I don't think that there is enough conversation around preventative health. The conversation about many of the diseases that we talk about, be it high blood pressure, be it cancer, be it menopause, really the conversation has to be backed up almost 20 years. You need to know what to do to not have these things, not deal with them after the fact.
And what is it that women are dealing with when we talk about menopause? I think you and I know myself and our photographer Penny, we talk about that often.
Yeah, well, you know, the one thing that women think of when they think of menopause is hot flashes. And yes, you do get hot flashes, but there are over 34 symptoms of menopause that you may or may not associate with menopause, such as dry skin, decreased libido, painful sex, frequent urinary tract infections, sleeplessness, depression, increased weight. All of these things sort of happen, and you may have all of them, may have 2 or 3, but if you don't understand that they're all connected to this phase, not just when your periods stop, but when you are transitioning, and that's the phase called perimenopause. And not enough women are aware of the fact that that can go on for as long as 10 years before your periods stop.
You are right about that. I've heard women talk about it and they don't know about it until they're almost at the end of it.
Exactly. And you know what? And I think young women think, oh my goodness, this has nothing to do with me. Well, yes, it does. Because as I tell women all the time, menopause is the one universal female experience. You may have a lot of things. You will have menopause if you are lucky to live long enough to get it. And so being able to prepare, to know the kind of healthy behaviors that you need to start instituting in your 20s, in your 30s, such that you can enter menopause at least more healthy than you would have been otherwise. But the other message I really want women, and particularly Black women, to get is that we do not use hormone therapy nearly to the extent that we should.
But they're scared. Many have.
I know. And you know what? And we in medicine have to really own that, because that fear, and particularly the fear of breast cancer, really was sown over 20 years ago by one vastly overquoted and misinterpreted study, the Women's Health Initiative. But the reality is that women, and Black women in particular, tend to go through menopause earlier. Their symptoms are more severe and they last longer. And having hot flashes and sleepless nights increases your risk for cardiovascular disease and increases your risk for diabetes and weight gain, a lot of the things that are, again, risk factors for other more serious diseases as we age. So the message to Black women out there is that there is no virtue in enduring, and saying, oh, I'll just get a fan or turn the air conditioning down. No, you should treat those hot flashes because they are an indicator of other things that could be problematic for you later in life. So, I talk about this in my book and sort of deconstruct some of the mythology and the misinformation that we have around hormone therapy. I think that the people who are most at risk are the same people who are least likely to complain about it and least likely to get a prescription and be treated for their symptoms.
But isn't there the concern that with the hormone therapies, it may increase their risk for cancers like breast cancer? That is something that many women have brought up.
Let me put that in perspective for you. For women who have had hysterectomies, and in that case, you can take estrogen only. You don't have to take estrogen and progestin. For women who take estrogen only, the risk of developing breast cancer, and this is from the same study that told you that it increases your risk, is decreased by 23%. And the risk of dying from breast cancer, even if you are diagnosed, is decreased by 40%. Now, where was that headline? You didn't hear it, did you? Well, that is why, again, this is a particularly important message for Black women because we do know that for Black women, the likelihood that you will die from breast cancer is 40% higher. So there's almost no reason for women who are at risk for breast cancer. A family history of breast cancer is not a contraindication to taking hormone therapy. And a lot of us take that off the table because we go, oh, I can't take that. I'm just going to suffer. No. The new guidelines for prescribing hormone therapy, a family history of breast cancer is not a contraindication. And let me tell you the other things that, there are a lot of things that we also need to know about women who take hormone therapy. It decreases your risk of cardiovascular disease by anywhere from 30 to 50%. And we know that cardiovascular disease, hypertension, diabetes, these things are much more prevalent in African American women. So, there are a lot of good reasons to take, and even the current guidelines say now that the best time to take hormone therapy or to institute taking hormone therapy is within 10 years of when you've had your last period.
Excuse me.
Or before age 60. So, there's no value in waiting. You treat when you are symptomatic because, again, having hot flashes, having night sweats, being sleepless or having disturbed sleep increases your risk for cardiovascular disease. And that is why I'm out here hammering this message home. If you are symptomatic, get treated. Because a lot of the things that you think are reasons why you shouldn't are just basically not true.
Let's talk about your visit here to Roswell.
Yes.
What do you say to the women or the people, because you're at a cancer institute?
I talk in my book, and I don't, I want to tell you, I talk about a lot of things. And one of the things that I do stress in the book is cancer, but cancer prevention. Because I think that, so much of the conversation is really focused on treatments and new and innovative treatments, but we can do both at one time. We can still innovate and be on board for all the research that needs to be done, but we can also learn about healthy behaviors that we can institute before we get cancer. What can I do to minimize my risk? And those are the things I talk a lot about in my book, because I think that as women, we have to do two things, and when I have my little a advocacy hat on, and that's what I talk a lot about in my book, is what are the things that you can do in your daily life to minimize your risk? And it's really not a lot of things, and they're not complicated. But there is the other part of it, which is, I say, my other hat when I wear my big A advocacy hat. And that is where I want women to understand how much we have been under-researched and underserved when it comes to many of the things that affect us in midlife. And that is where we have got to advocate collectively, because the NIH, which is the major funder of research in this country, does not serve women well. of a $45 billion budget in 2022, less than 11% of that budget went to conditions that affect either exclusively or primarily affect women. And we have got to get away. We have developed an I would say an indifference to women's suffering. Mm-hmm. We've included that in our language. Oh, well, she suffers from migraines, or she suffers from fibroids, or she suffers from depression. That has become the expectation of what a woman's lived experience is supposed to be. And I'm like, no, let's not do that.
How do we debunk that, though?
Well, what we're going to do is that, again, when we put on our big A advocacy hat, we're going to demand that a lot of the things that we don't have answers to, that we do the research and get answers to. It's not enough to just describe a problem, because I think the next step is why? Why? And then what are we going to do about it? And this is a particularly important message when it comes to women of color, because even of that 11%, when it comes to addressing the health disparities that we know exist, we just talk about them. We do very little about them. And I think that that's where we've got to outreach to communities. We've got to make sure that people of color are included in clinical trials. And then we have got to go about the business of investigating why and the what and how we're going to live healthier lives.
Maternal health is a big issue for women. So many women either cannot conceive, or once they do conceive, they're having issues in delivery. We're hearing about maternal disparities, women dying. But as we just discussed, sometimes the numbers aren't as, there are other issues that lead to these problems.
Well, when we think about maternal health, and it's, you know, I spent my career as an OBGYN, and I've delivered lots of babies, and I'm, you know, sometimes you have to say, you have to stay vigilant, but we have to educate women. We have to know that how you will do in pregnancy really depends on what your health status is going into a pregnancy. And even with that, we as doctors have to know how to monitor and to really to do better by those women. Because if you come into pregnancy with hypertension, then I need to know that you need to be treated differently and monitored more than someone who doesn't come in with that finding. But let me say this. One of the things that comes up consistently when we're talking about healthcare disparities, whether we're talking about high blood pressure or cancer or maternal health, there's probably I would say one of the drivers of that disparity is really not what's wrong with Black women or what are we doing differently. It is the lived experience of being a Black woman in America. And what does that do? How does it affect your health to be chronically stressed? How does it affect your health not have clean water or to live in a safe neighborhood? All of these things that are outside the individual, that are matters of policy about how we deal with communities at risk, these are things that can be addressed. We just need the political will to do so. And I think that that is something that we as women and we as in communities of color have really got to demand, because it's not, we don't need another observational study to see what we're at risk for. We kind of know that. But let's do better. Let's make sure that women are involved in the solution. I think that when we are healthy, when women are healthy, society is healthier. Because who are we? We are the caregivers. You know, we are the ones that are nurturing the next generation. We are role models for our children. And so yes, our health matters, but not just, you know, not just in our reproductive years, because I think that is important. But I think that my role is to advocate for women in midlife, because all of it matters. We're going to spend far more of our lives in our post-reproductive years than we are going to spend in our reproductive years. And let me just say, as women, we are more than just our reproductive parts. Menopause is a total body experience. There is nothing in your body that isn't affected by the presence or absence of estrogen. So the more we know about that, we not say, wow, I've got itchy skin, or I've got dry eyes. All of that stuff, everything in your body is sensitive to estrogen, not just your ovaries and your uterus.
Going back to maternal health, women having children later than they once were.
Yes. Well, if you just think about it, as I told you, it matters what your health is going into a pregnancy, right? Well, we are now at a phase in this country where women are giving birth later than we ever have before. The average age at first birth now is 29. There are more women giving birth voluntarily over the age of 40 than there have ever been. And let me say that just giving birth later gives you more time to accumulate some of the health problems that may be problematic in pregnancy. And we always thought about, oh, well, older, all we had to worry about were chromosomal problems. No, it matters. It matters whether or not you come into a pregnancy, whether you have hypertension or whether you have diabetes, or at risk for things that could put you and your baby at risk during a pregnancy. So we have to take that into account, that again, our lived experience is such that we're not having babies at 20 for the most part. We're having babies at 30, 35, 40. And so how we care for women during those phases of life have to take that into account.
Are you excited about being here in Buffalo? And what is the main message? And I'm sure you probably have studied some of the issues and some of the women's health issues, which are pretty much universal, but is there something specific you want to tell the audience of women in Buffalo?
Well, first I have to say I'm delighted to be here and to be invited by Roswell Park to come in, because I think that they are really trying to do some of the things that I've been talking about, not just being on the cutting edge of cancer treatment, but reaching out to the community to explain what kinds of things you can do for cancer prevention. How do you screen? All of these things are important. So I am delighted to bring my message of prevention to the cutting edge technology and outreach that Roswell Park is trying to do.
Is there anything else you want to add?
What I want to add, I talk a lot about health, about menopause, but I always like to leave people with a very positive message. And the positive message is this: how you fare in your later years really depends on how you treat yourself in your younger years. And just because you have a family history of something does not mean that you are destined to the same. And I think a lot of us throw our hands in the air and go, oh, well, my mother had cancer or somebody, and you think that that is your destiny. And I'm here to tell you it is not. Your family history only tells you what you are predisposed to. But you and your family share a lot of things other than genes. And a lot of those things that you do share, like your environment, like your diet, like your lifestyle, are things that you can modify. So the hopeful message is that we can and we should do better. And I think most of us want to do better if only we knew what to do. And that is why I wrote my book. I want it to be that guidepost for whether you're 20 or 30 or 50 when you're reading it. There is an entry point for everyone to improve their health.
The name of the book?
Grown Woman Talk.
Penny, anything?
You can answer the question, Claudine. What about women that, I suppose no matter what nationality they are, they go through menopause early, like me. I hit peri at 36, hit menopause at 41. What do women like me we need to watch out for going through menopause early? Because I think a lot of people are like, that's happening.
Yeah, that's true.
For women who go through menopause early, and let me tell you what's early. If you have had your last period before the age of 45, that puts you at risk, more at risk, for things like cardiovascular disease. It puts you at higher risk for Alzheimer's disease. All those things that we talk about that happen after menopause or within 10 years, those risks are higher if you go through menopause earlier. And the current recommendation for women who go through menopause before age 45 is that the recommendation is that you should take hormone replacement therapy at least until the average age of menopause, which is 51. But there are a lot of women out there that say, oh, I didn't get that message, or someone didn't tell me. Why didn't someone tell me that? Again, something that not many women knew is that if you go through an early menopause before age 45, or premature menopause, which means being menopausal before age 40, you're at higher risk for cardiovascular disease, you're at higher risk for Alzheimer's, you're at higher risk for a lot of those chronic conditions that we talk about, such as diabetes. And how about this? Your quality of life is diminished. You know, at 40 or 45 years old, these are women who are trying to live their lives. You know, one of the symptoms that women have is brain fog. You know, it affects the quality of your life, not just the length of your life. And so these women they should be treated, particularly if they are symptomatic. And I think that there are a lot of women out there that are saying that, well, now they're 60 and you told me I should do this before age 60 or within 10 years and I'm farther out. Well, here's something that I want you to keep in mind, that there are conditions. There's a condition called the genital urinary syndrome of menopause, which is just dry vagina, painful sex, urinary tract infections, urgency, frequency, everything that affects the genital urinary symptoms. Every woman can take vaginal estrogen, which is just local estrogen. It's used in the vagina. It treats those symptoms, and it also improves the quality of your life. And for women as they age, it decreases the risk of urinary tract infections. And if you look in nursing homes and you say, what's one of the more common reasons for being hospitalized? Urinary tract infections and all the things that happen from that. So even though you might have missed the boat, and I think that is unfortunate because we've done an entire generation of women a disservice by not having this conversation earlier. Every woman, regardless of whether you've had breast cancer or you're beyond the window, can and probably should use vaginal estrogen.
I think your message is so important, and Penny, thank you for bringing that up, because I mean that's true. Like,
yeah.
If you missed it or you didn't know and
right.
you're past that point, like,
right.
Do you feel like you're done? Like,
right.
Should she feel like, okay, it's over, I'm going to hit all those things?
Well, a lot of the things that we associate with menopause, particularly like hot flashes, hot flashes will eventually go away for most women. Now, 20% of women will still be having hot flashes at 75, and let me just say, they're not happy about it. Right. But for most women, they will go away. But the message I want to give is just because your hot flashes went away does not mean that that lack of estrogen is still, sort of causing other issues that you may or may not be aware of. Women have half the risk of heart disease than men do, but only before menopause. Within 10 years of having had your last period, the risk of cardiovascular disease, heart attack, and stroke goes up for women. It is equal to or it exceeds the risk of men. And the theory is that those 10 years of the lack of estrogen really is one of the risk factors that increases that.
Education, I mean, when we listen to everything you've said so far, it really boils down to making sure that women are educated.
Exactly. And that's my job. And let me say this, because, people say, oh my goodness, Dr. Malone, you are, I'm the Chief Medical Advisor for Alloy Women's Health, which is a telehealth company that does just this. It makes sure that women are educated and that women have access to hormone treatment. Because even today, in 2024, there are still women who cannot find doctors who will prescribe for them. They're not adequately trained in how to treat menopause, and they will actively discourage symptomatic women from taking. Well, that's a problem. And I want all women, whether you live in Schenectady or whether you live in Sarasota, Florida, every woman should have access to good quality information, fact-based information, and have access to hormone treatment, even if you can't find a doctor who will prescribe. And that's why we work in the telehealth environment.
I think it's important to have that voice and to hear it come from you. I know you're friends with Michelle Obama, but another person, when you hear that from her voice, and for somebody who looks like you that people can relate to, and even if they don't look like you, I'm thinking about Penny, and I know exactly what's going on in her mind right now. She was like, she's going to tell me in the car, that was awesome. We needed to hear that. Women need to hear this.
Well, and you know, because the message is all women need to hear it. It is especially true for certain groups like African American women, even Hispanic women, because they are least likely to get the message and to be more sort of, I would say, influenced by some of the misinformation. So that's why I use that focus, but there is nothing that I'm saying that does not apply to all women. And for those who would say, oh, well, Dr. Malone, you're just pro-hormones. And I say, no, I am not pro-hormones. I am pro-women's health. And anything that I can do to affect that, that is what I want to talk about.
Love it. Thank you so much for doing this.
Okay.